everybody, I'm Dr. Meenakshi, one of the mentors at StudyMRCOG. So today's topic for discussion is histopathology of cancers. So as we always start with a quote, it is important that we never give up because someday it is going to be ours and definitely we are going to succeed. So do not stop trying and always believe in yourself, and that is the route to success. So we will be having a discussion about the cervical cancer, the endometrial cancer, vulval cancer and ovarian cancer regarding the histopathology. So what all do we need to cover today, or what we need to learn in terms of oncology is the lymphatic drainage of vulva, the classification of tumors. It is very important that we read about the classification and FIGO staging. FIGO staging of cancers is an extremely important area where questions can be expected. So they could be just giving a scenario and they would be giving a series of options wherein you have to choose to which stage does the cancer belong to, or they could sometimes give the description and you would be asked to to write about the plan of management as well. So it is very, very important that we know the FIGO staging by heart for all the 4 cancers. And then the 5-year survival rates, then the hallmark in the histology. Like as we go through today's session, you would be getting a few examples regarding the histological hallmarks of certain kind of tumors. And tumor markers are also very important. Like for example, if it's alpha fetoprotein is secreted in high amounts, then we suspect yolk sac tumor. So such questions can also be expected. And management of each stage of cancer, just as I have discussed. Not necessary that we know about the entire management regarding the steps of radical hysterectomy, for example. Not necessary that we need to know in detail, but for each stage, how are we going to manage? At least the outline of the management is important. So this is a very important hot topic wherein SBS as well as EMQs both can be expected in this. So first is let's discuss about the cervical cancer. So today's class is going to be regarding the histopathology of all the 4 cancers. So cervical cancer, the most common presentation we see is the squamous cell carcinoma. It can be keratinizing, non-keratinizing, papillary, basaloid, warty, verrucous, squamotransitional, lymphoepithelioma-like. Or it can be adenocarcinoma, which can be endocervical, mucinous, villo-glandular, endometrioid types. Clear cell adenocarcinoma, serous carcinoma, adenosquamous, glassy cell carcinoma, adenoid cystic carcinoma, adenoid basal carcinoma, small cell carcinoma, and undifferentiated carcinoma. So as we all know, the precursor is primarily the human papilloma virus, HPV, and out of which 16 to 18, the variants contribute about nearly 71% of the cases. The rest of the types would be 31, 33, 45, 52 and 58, which contributes to about 19% of the cases. So although we can histologically we tell that there is SIN1, SIN2, SIN3 like CIN1, 2 and 3, it is actually very subjective. And that is only for the subjective purpose, of a descriptive purpose we tell, but actually it is very difficult to differentiate. And how do we call this as SIN 1, 2 and 3 is that in SIN 1 we have the abnormal cells which extend only up to 1/3 of the thickness, whereas in SIN 2 we see that about 2/3 of the thickness of the epithelium the abnormal cells have already invaded, and about 75% of the thickness will be involved in the severe dysplasia or the SIN 3. So in this we also have the others like the low grade as well as the high grade squamous intraepithelial lesions. So as we can see, this is the histopathological feature of L cell, where you see that these cells are having a lot of vacuolated cytoplasm. There is an abundant vacuolated cytoplasm, plus we also see that the nuclei are enlarged. So these are the typical features that we can see in L cell. When it comes to H cell, we see that the cytoplasm, it becomes very scanty. In L cell, it is abundant and it is vacuolated cytoplasm, whereas in H cell, that is a higher grade of abnormality. You see that the cytoplasm has become very scanty, and the nuclei is also hyperchromatic, and they have also got the irregular borders, and the nuclei, they become irregular in shape, plus they also become hyperchromatic. So in invasive cell carcinoma, the cervical carcinoma, as we've seen, the squamous cell type, that is the majority of the cervical carcinoma, which is squamous, and it is followed by adenocarcinoma, and then the other variants could be like adenosquamous, varicose, as well as undifferentiated types. So this is the histopathological examination of the invasive cervical carcinoma. As you can see that these are the tumor cells, and then you can also see the stroma, which is infiltrated with the inflammatory cells, plus the nuclei is also showing the presence of mitotic figures. Whenever there is a mitotic figures, then it is definitely an indicator of a malignancy, which is definitely abnormal. So the invasive carcinoma cervix somewhat looks like this on histopathology. So if we can see, this is about the histopathology, but the important topics that you need to cover in when you read about the carcinoma cervix is the NHS screening pathway regarding how do we screen for cervical carcinoma. It is a very, very important charts which we are having. Like firstly, we do the high risk HPV test, and based on the result, we proceed towards cytology, and then we have to proceed towards colposcopy based on the cytological appearance. So there are the beautiful flowcharts which are available. So please go through it. It's very, very important topic. So this question has been taken from the chart itself. We see that a 45-year-old patient coming with reports showing human papillomavirus positive. So because she was HPV positive, we did a cytology which shows mild dyskaryosis. And then because the cytology is abnormal, a colposcopy was done, which was negative. So what is the follow-up of this patient? So as we go through the chart, we get to know when is the recall for the patient, like do you call in 1 year or do you call in 3 years? How is the follow-up? You have to go through the chart. So please do not forget going through the chart. And since here we see that although the cytology is a mild variant, since the colposcopy was negative, we call the patient for a routine recall. So the commonest gynecological malignancy which is detected in pregnancy is cervical cancer. So this is also another important question. Now next we move on to the endometrial cancer. So the endometrial cancer is actually the most common gynecological malignancy in the Western world, and the endometrial hyperplasia is its precursor. And most of the endometrial carcinomas are adenocarcinomas. In cervical, it is squamous. In endometrial cancer, it is adenocarcinoma, and they are called as adenocarcinomas because of their resemblance with that of the normal endometrium. So the most common cancer, gynecological cancer, is endometrial cancer, while the most common gynecological malignancy detected in pregnancy is cervical cancer. So the histopathological classification of the endometrial carcinoma includes endometrioid carcinoma, that is nothing but the adenocarcinoma or the adenocarcinoma variants, and then you've got the mucinous adenocarcinoma, then serous adenocarcinoma, and clear cell adenocarcinoma, undifferentiated carcinoma, neuroendocrine tumors, and mixed carcinoma, that is carcinoma which is composed of more than one type, that is having at least 10% of each component. So here the most common is going to be adenocarcinoma. So as we've just discussed that the most common precursor for the endometrial cancer is endometrial hyperplasia. We've got different variants in this. One is endometrial hyperplasia, which is without atypia, and the other one is with atypia. So first let's discuss about the cystic endometrial hyperplasia. That is nothing but sometimes it can also be seen in conditions such as PCOS, wherein the endometrium is not shed because of irregular cycles, and there is a thickening of the endometrium, which is the cystic endometrial hyperplasia. So as you can see, the name itself, cystic, which means that there is a cystic dilatation of the glands, and then the stroma is very compact, and here you can see the nuclear stratification. Okay, so this is the histopathological appearance of a cystic endometrial hyperplasia. So cystic endometrial hyperplasia, the chances of it to turn into malignancy is extremely less. It could be less than 1%. So this is again the endometrial hyperplasia without atypia. As you can see that the stroma is very dense and compact, and here you can see that the endometrial glands are, this is called as back-to-back arrangement of the endometrium. As you can see, this is the endometrial glands. Here we call it as back-to-back arrangement. That means that the glands are enlarged, and there will be infoldings, which are the like papillary infoldings. These you can see like finger like projections, which you can see. So all these, and because the glands are crowded, we call this as a back-to-back arrangement of the glands, which is one of the important histopathological features. And then we have got with atypia. When endometrial hyperplasia is associated with atypia, it is very similar to that without atypia. That means that the glands are crowded, and again we can see that there is a back-to-back arrangement of the glands here. You can see that it is very much crowded, and also you can see these papillary infoldings. But the other important feature which helps in differentiating with and without atypia is this nuclear atypia. Whenever there is some nuclear changes which are like which could be precursors, or they could be the signs of malignancy, so inside, that is the only difference we see in without atypia and with atypia. Rest features are very similar. So in cystic endometrial hyperplasia, so this is characterized by the presence of large number of glands which are cystically dilated, and their epithelium is atrophic. Mitosis is scanty, and there is no atypia at all. The stroma between the glands is sparsely cellular, and it is edematous. And then is endometrial hyperplasia without atypia. So the glands are increased in the number of size, and they also become irregular. They increase in both number as well as size, and they become irregular. So as we can see that they are lined by the tall columnar epithelial cells with large nuclei, and they have not lost the basal polarity, and there is no significant atypia. The stroma is again dense, cellular, and compact. And when there is atypia, there will be loss of polarity. The cell polarity would be lost, and the nuclei, they become large and they become irregular. They take up a lot of chromatin, that is hyperchromatic nuclei, and also the nucleoli become prominent. And as we can see here that the nucleus is increasing in size, the nuclear cytoplasmic ratio would be altered. And as we can see that the risk of endometrial hyperplasia, if there is no atypia, if it's like a simple endometrial hyperplasia without atypia, the chance of it to progress towards cancer is less than 5/20 years, which is again another important question. So as we know that it could be differentiated as well differentiated, moderately differentiated, and poorly differentiated. So this is about the well differentiated endometrial cancer. So we have discussed about endometrial hyperplasia both with atypia and without atypia. So next it is progressing towards cancer. So in this endometrial carcinoma also we see that it is very similar, that is the back-to-back gland arrangement and everything is there, but you see that there is a stromal infiltration as well. As you can see that initially the stroma was very dense and cellular, but here the stroma, it has completely, the cells, the glands have infiltrated into the stroma, so therefore the quantity has become less, the proportion has been altered, and here even the cells are also showing some kind of typical changes. So the cells could undergo any change like anisocytosis or poikilocytosis, anything it could occur. So all these atypical changes including the cells, have also undergone here. So the back-to-back gland arrangement is similar to both hyperplasia and cancer. The only feature which differentiates it between them is the appearance of features such as mitotic figures, or like nuclear changes such as hyperchromatic nuclei with altered nuclear cytoplasmic ratio, and also cellular atypia. So as we can see that in well differentiated, the number of glands have increased, and there is an obliteration of intervening stroma. And also the epithelium shows stratification, formation of tufting and papillae, and atypical changes. And most of the growths are well differentiated. In moderately differentiated, you have all these features, plus the malignant cells are also present as sheaths. Whereas in poorly differentiated, we see that the glandular pattern which you normally see, like the back-to-back gland arrangement and all, that is very hard to find. You can only see that there are sheaths of cells, and also there will be cytological atypia, and mitotic figures also would be more, but the glandular pattern is very hard to find. So most common gynecological malignancy in Western world is going to be endometrial cancer. So a 62-year-old woman is taking tamoxifen following surgery for breast cancer. She has experienced some vaginal bleeding, and a transvaginal ultrasound shows her ET is 7 mm. What do you want to do next? So this tamoxifen is actually a selective estrogen receptor modulator. It is known to suppress the estrogen receptors in the breast, but it has the positive agonistic action towards the estrogenic receptors in the endometrium. So therefore, for women who are on tamoxifen, the endometrium gets thickened, and the cutoff value that we take is 7 mm. Whenever it is more than or equivalent to 7 mm, it is important that we have to go for a hysteroscopic and a targeted biopsy. So this is an important point. If it is so because she is on tamoxifen, it is expected that the ET would be, the endometrial thickness would be increased, or it would be thickened. But there is a certain particular cutoff value that we do. So when it is showing that when she's on tamoxifen and she's experiencing bleeding, we expect the endometrium to be thickened. So therefore, to rule out if there is any concomitant endometrial cancer as well, we have to take up a biopsy in order to rule out. So that is also very important point. So the next one is leiomyosarcoma. So leiomyosarcoma is the uterine cancer, and this has got a very different typical appearance, where we can see that these are the like whorls of cells. This is called as the whorl pattern. So we see that the smooth muscle cells, that is nothing but myosarcoma, that means it is coming from the myometrium. So these are the smooth muscle cells. So these are the smooth muscle cells which are going on, they are like arranged in the form of spindles, and the nucleus is oval in shape. As you can here clearly see that these nuclei are oval. So whenever that is oval in shape, the cytoplasm is also found to be abundant. So, and here you can see that there is a hyaline change as well, and so having a typical whorl pattern is the characteristic feature of leiomyosarcoma. Next is the ovarian cancer. The ovarian cancer is the leading cause of death from the gynecological cancer. The most common gynecological cancer in the Western world is the endometrial cancer, whereas the most common cause of death from a gynecological cancer is the ovarian cancer. So in the histopathology, we have got, there is a different classification like serous, mucinous, endometrioid, clear cell tumors, Brenner's tumor, undifferentiated, and mixed epithelial tumors. So sometimes it is also possible that the ovaries and fallopian tubes could be involved because of secondaries, and the primary is not the ovary. So this is just nothing but a basic representation of how the stromal invasion is occurring, or how the cells are growing. As you can see that this is a normal stroma, and here you can see that there is a single layer of epithelium. So this is definitely a benign condition. and then you can see that the epithelium is increasing in the number of layers. That means that the stratification is occurring here. And also the cells, there is a change in the morphology. As you can see that there is some kind of atypical changes which are occurring. So this is the borderline. And then as you can see in the last, here we get to see that not just there is a stratification of the epithelium, but so there is an increase in the number of the layers which is happening, plus there is also some kind of stromal invasion. As you can see that the cells are invading into the stroma. So the next one is the papillary serous cystadenocarcinoma of the ovary. So here it is also very similar, just as we have discussed, that there will be an increase in the layers of the epithelium, that is the stratification. The cells would be showing signs of atypia with stromal invasion, and the important thing is the psammoma bodies. So this is said to be one of the pathognomic features of cystoadenocarcinoma of ovary, that is the serous cystadenocarcinoma. So psammoma body can also be seen in other cancers as well, but it is not necessary that it is exclusive to the papillary serous cystadenocarcinoma, but it is the pathognomic feature. And next is mucinous cystadenoma. As you know that since the name itself indicates that there is a lot of mucin content, so you can see that there is a lot of this mucinous fluid which is seen here. Typically we don't get to see the stratification, but we see the mucinous fluid, which is the pathognomic feature. So as we have just discussed that the serous cystadenocarcinoma, there is a multi-layered malignant cells with loss of polarity and presence of solid sheets of anaplastic epithelial cells, and also definitive evidence of stromal invasion. It can be associated with psammoma bodies. In mucinous tumors, piling up of malignant epithelium at place which is forming solid sheets, papillary formation, adenomatous pattern, and infiltration with or without the pools of mucin. Next one is the clear cell tumor. As you can clearly see that here we have got some tubules or glandular papillae, cysts, and solid sheets of tumor cells. Clear cells which is having eosinophilic cytoplasm which is rich in glycogen. So this histological appearance is very, very clear that this would be belonging to a clear cell tumor. As you can see that the cytoplasm here is very, very clear, and this has got some abundant of glycogen. So that is eosinophilic. As you can see that because of the pink stain, it is eosinophilic rich cytoplasm. And next, this is the Brenner's tumor. In the Brenner's tumor, we see that there will be some nests of cells, masses or columns, and here we can see the fibrous stroma of the ovary. And here you can see that they are ovoid in shape with clear cytoplasm, and there is a vesicular nuclei with characteristic nuclear groove, and this is called as coffee bean nuclei. As we have discussed in the initial phase that the histological hallmarks of tumors are very important. This is one of the important points. As you can see, like a coffee bean. Similarly, here the nucleus is also known to have a typical appearance like a coffee bean. So coffee bean nuclei would come for the Brenner's tumor. So this is an important point. Next is the dysgerminoma of ovary, and here also we can see that there is a sheets of fibrous stroma, and these are like the fibrovascular septa, and then you have got the tumor cells, and here they will be having a clear cytoplasm, and they have the vesicular nucleus, and this is also having an eosinophilic appearance. These are also rich in glycogen. Next is the yolk sac or endodermal sinus tumor. The pathognomic feature is Schiller-Duval bodies. So these are certain catchy points that we need to remember. from the entire scenario, these kind of hot points can be expressed in the question. So even if the entire scenario could not be understood, by just catching these points, probably we'll be able to guess the answer. So here we see in the yolk sac tumor or the endodermal sinus tumor, also called as endodermal sinus tumor. So here we see that there will be the, whatever the tumor cells are present, they will be like, you can see they are like papillae like projection. As you can see, they have a papillae like projection, and you will be having a blood vessel, and surrounding this you will be getting the anaplastic cells. This is called as Schiller dual body, which is characteristic of yolk sac tumor or endodermal sinus tumor. And then we have got the granulosa cell tumors. The characteristic feature is the Cole-Exner bodies, which is very, very important. That is Cole-Exner bodies. As you can see that here they are characterized by the presence of characteristic rosette-like structures. So here you can see that this is nothing but this is like a central mass which is actually surrounded by a granular cells. So here you can see the granulosa cells, which is a granulosa cell tumor, right? So it is surrounded by this. You will be having a center around which it will be arranged. That is called as Cole-Exner bodies, which is a typical feature of the GCT or granulosa cell tumor. Next is the Krukenberg's tumor. Krukenberg's tumor, the typical feature is the signet ring-like cells, which is nothing but you will be finding like a mucus filled like cells, and here see, as you can see, the nucleus is pushed towards one center, so therefore pushed at one end, which will be giving the appearance of the signet ring like cells. So it gives like this appearance. So this is a typical feature of the Krukenberg tumor. So as we have discussed, let's put it in a gist that Brenner's tumor, the characteristic feature is the coffee bean nuclei. For yolk sac tumor, it's Schiller dual bodies. For granulosa cell tumor, Cole-Exner bodies, and for Krukenberg's tumor, it is signet ring cells. So a 55-year-old woman is referred to the gynecological oncology for postmenopausal bleeding. An ultrasound shows thickened endometrium and a solid ovarian mass on the left side. And an endometrial biopsy shows grade 1 endometrioid carcinoma, and she undergoes a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Her CA-125 is 150 units, and inhibin B levels are said to be elevated. So she undergoes a staging laparotomy, and what would be the likely histological diagnosis of ovarian mass in her case? The entire question is a long scenario. Sometimes these questions, such questions of such length can also be expected, but there would be one catchy point. So as you can see here that the point that you need to note is the inhibin B. So where is the inhibin B secreted? It is by the granulosa cell tumor. Sometimes you can also be asked regarding the LDH or alpha-fetoprotein. Such kind of questions can also be expected. So it is important that we also need to know about the tumor markers. Next, a patient is noted to have symmetrical bilateral ovarian tumors which are removed. So the histopathology shows tumor cells which has a signet ring-like morphology, and that raises the possibility that it is a metastasis rather than a primary malignancy. What is the most likely primary site? So we see that for Krukenberg's tumor, the most common primary comes from the gastrointestinal tract, and that too primarily from the stomach. Also it could come from gallbladder, pancreas or intestine, but primarily it is from the stomach. Also the secondaries to the ovaries is also possible through the breast. So either it can be a breast cancer, but most commonly it is the GI tract and that stomach. So let's discuss about the last one, that is the vulval cancer. So we have got like certain risk factors, like in older women, the lichen sclerosis or the differentiated type of the vulval intraepithelial neoplasia that would be progressing towards keratinizing type of squamous cell carcinoma. Whereas in younger women, the precursor most commonly is the HPV persistently, which is present, variants of 16, 18, 31 and 33, and SIL, squamous intraepithelial lesion, could be the precursor, and HIV in cigarette smoking is also one of the risk factors, and the most common variant which is found is the warty or the basaloid type of squamous cell carcinoma. So in older women, it is the keratinizing type with lichen sclerosis as the backdrop, whereas in younger women, it is the warty or the basaloid type of squamous cell carcinoma. So either way, either it is coming because of lichen sclerosis or the HPV, the primary stage which it has to go through is the WIN, which is the vulval intraepithelial neoplasia. So we have got two different types. One is the differentiated and the other one is called as undifferentiated. Differentiated is associated with lichen sclerosis, whereas undifferentiated, that is which occurs on the background of human papillomavirus, we say it is otherwise called as usual type or the classical type. So undifferentiated or usual or classical type is associated with HPV, whereas the differentiated WIN is associated with lichen sclerosis. So in case of vulval intraepithelial neoplasia, you see that the changes such as hyperkeratosis, parakeratosis, acanthosis or coilocytosis and presence of atypical anaplastic cells will be present throughout the entire thickness of the epithelium. So as you can see, this is the histological appearance and this is the mitotic figure. As you can see, these are the mitotic figures, which is the characteristic of the malignancy. So which type of vulval intraepithelial neoplasia is associated with the greatest progression to squamous cell carcinoma is the differentiated type, which occurs on the background of the lichen sclerosis. So that is said to be the most common type because vulval carcinoma usually presents in older age rather than the younger age group. Most commonly the prevalence occurs in older age group. So the differentiated type is the most common type. So to which group of lymph nodes does a squamous cell carcinoma of the vulva initially spread? It is the inguinal group of lymph nodes. As I told that the lymphatic drainage of the vulva of all external genitalia, it is a very important topic in case of oncology. So we need to read about that as well. So that's it regarding the histopathology of the gynecological cancers. I hope you found this useful. In case of any kind of doubts, you can just let me know in the comments below and do not forget to subscribe to the channel. So I will see you all in another one. Thank you and happy studying.